Welcome back to What the Study Says, where we crack the case on complex medical topics. Today, we're putting on our detective hats to investigate a sudden, dramatic, and all too common medical emergency.
So I want you to imagine this for a second. One moment you're going about your day, and the next, you're gasping for every single breath. It's this terrifying sensation, like you're drowning, but you're on dry land. Well, that horrifying 911 call is what kicks off our investigation today. It's a medical mystery that brings over 1 million people into the hospital every single year.
Now, this feeling, it has a name, and it's our primary culprit, acute decompensated heart failure, or ADHF for short. So what's really happening? Well, think of your heart as this tireless pump. In ADHF, that pump suddenly just can't keep up. And the result? It's a massive traffic jam in your circulatory system, causing fluid to back up into your lungs and all over your body.
To solve any case, right, every good detective has to start by profiling the problem. You gotta understand its rap sheet. So let's ask, just how big of a deal is ADHF, really?
Well, let's start with the money. We're talking about over $30 billion. That's billion with a B. And that's just the annual direct cost of heart failure in the U.S. alone. So, this isn't some rare, obscure condition. It is a massive public health issue with an absolutely staggering economic footprint.
In fact, ADHF is one of the top reasons older adults get admitted to the hospital. We're talking more than 1 million cases every year between the US and Europe. And get this, when these folks show up in the emergency room, 3 out of every 4 of them are getting admitted. This isn't a go home and rest situation, it's a true medical emergency.
Now, a key part of our investigation is figuring out who we're dealing with. Is this a first-time offense, or are we looking at a repeat offender? New acute heart failure is exactly what it sounds like, a first-time event, a totally unwelcome surprise. But what we see most often is the repeat offender, a patient who already has a diagnosis of heart failure and is having a sudden flare-up. And knowing that distinction, it's absolutely crucial because it completely changes our immediate line of attack.
Okay, so we've profiled the problem. Now let's do what any good detective would do. It's time to round up the usual suspects. What are the common triggers that can push a stable heart right over the edge into decompensation?
And this is where the case gets really interesting, because the triggers can come from anywhere. Sure, some are directly heart-related, things like a blocked artery or a chaotic heart rhythm, but check out the non-cardiac causes. The biggest culprits are often things like just forgetting to take your medication, or a simple dietary mistake. Yes, I'm serious. A salty meal, like a big bag of potato chips, can literally be the thing that lands you in the hospital.
So with our list of suspects in hand, it's time to open up our detective's toolkit. We need to start gathering some hard evidence to confirm our diagnosis and figure out exactly what we're up against.
Look, as doctors, we don't just guess. We're not just throwing darts at a board here. We use a systematic approach, a lot like this investigator's flowchart. It all starts with the patient's story and a physical exam, and then we move on to blood work, an EKG, a chest x-ray. It's a roadmap that makes sure we don't miss a single clue, so we can build a really solid case.
And for all that complexity, the entire investigation really boils down to answering 2 absolutely critical questions. Number 1, is there congestion? Is the system backed up with fluid, kind of like a plumbing clog? And number 2, is there good perfusion? Is blood actually flowing properly and getting to all the vital organs? These 2 clues, congestion and perfusion, they help us solve the whole puzzle. By figuring out if a patient is wet or dry from a fluid standpoint and warm or cold based on their blood flow, we can slot them into one of 4 distinct clinical profiles. And this classification, it's the absolute key to unlocking the right treatment plan.
Okay, we've got our clues, we've profiled our patient. Now it's time to crack this case wide open and lay out the master plan for treatment.
This algorithm right here, this is our master plan. And let me be clear, this is not a one-size-fits-all approach. Based on that specific profile, that warm and wet or cold and dry status, and their blood pressure, this map tells us exactly which tools to pull out of the bag, whether that's meds to open up the blood vessels or others to help the heart pump stronger. So what's really interesting here is that one of those profiles is way more common than the others. The research shows that most patients fall into the wet and warm category. What does that mean? It means their perfusion is actually okay. The pump is still getting blood out, so they're warm, but the plumbing is severely backed up with fluid. They are very wet.
So really, we can take that whole complex chart and simplify it down to 3 main goals to get the patient stable. First, get the extra fluid out of there. We use diuretics for that.
Second, we need to open up the pipes with something called vasodilators to take pressure off the heart. And third, if we have to, we directly support the pump with drugs called inotropes to help it squeeze more effectively.
All right, let's wrap up our investigation and file the report on this case. Case closed for now. Here's what you really need to remember.
Here are the essential facts for your detective's notebook. ADHF is that sudden fluid traffic jam from a struggling heart. The triggers are often surprisingly simple things we can actually control. The whole diagnosis hangs on assessing that fluid backup, the wetness, and the blood flow, the warmth. And most importantly, treatment has to be personalized to that patient's unique profile.
So this case might be closed, but it leaves us with one final, and I think, crucial question. We know one of the biggest triggers, especially for those repeat offenders, is just not sticking to the treatment plan. So that forces us to ask, what's the one thing we can do to really empower patients and prevent this from happening over and over again?
If you found this investigation insightful, please do us a favor. Subscribe and share what the study says. You can help other people crack the case on their own health and hopefully stay out of the emergency room. Thanks for joining me.